Did you know that research has shown nearly 77% of female EMS providers have reported sexism and harassment while performing their duties? And in that same group, nearly 61% report reconsidering their career choices. Research in EMS has proved to be a powerful tool, not only understanding the conditions in which people are working, but also a powerful advocacy tool that can lead to an improved environment and industry for all involved. Hi, I'm Robbie McHugh, your co-host of the EMS Leadership Summit. And today we're here with Dr. Molly McCann-Pineo, who is the Director of Clinical Research for the Emergency Medicine Services line at Northwell Health. And not only a trained epidemiologist, but also has 2 advanced degrees in public health and has been publishing EMS research since 2015. I find one of the most interesting facts is that despite all of her research in the environment and the conditions in which paramedics work, she is still planning to complete her basic EMT training. Molly, thanks for being with us today.
Thank you so much for this opportunity. It has been an honor to have been invited.
Yeah, we're so thrilled for you to highlight and really elevate the voices of women in EMS, to talk about EMS research. And maybe you could start out by sharing something about a story, or what has impacted you the most with, or surprised you the most, I guess, out of all the qualitative research that you've been working on.
Sure. So I think perhaps the most surprising was during one of our focus groups, a lot of pregnancy related concerns were brought up. And, I found what I was hearing very alarming. And I was actually pregnant at the time, and I have a very different situation in my occupation, in the comfort of my office. So a lot of these things were very alarming, and I felt this has got to change. We have to do something about this. I know people may seem, I'm not a clinician yet, I may be saying this from my ivory tower, but I know that research can provide very meaningful evidence. So I knew that this was the best chance that we could have to kind of catapult change.
That's great. And our theme throughout the summit and all our speakers is flourishing together. How do we give more ideas, create more ideas to create a thriving organization? And sometimes we've got to talk about the opposite side of that, the not flourishing and what's not working in an industry. And I know you've put together some great slides and to talk about the research, to talk, maybe you could give us a little bit of background about Northwell Health's emergency medical services and emergency medicine services and their line of health, because I believe some of the statistics are over 1,000 providers, specifically in the EMS division. Jonathan Washko was telling us.
Yes. So we have an enormous amount of active licensed EMTBs, paramedics. We have flight paramedics. Our community paramedicine program, we proudly have 70 trained community paramedics and growing. We are one of the largest EMS agencies and the hospital-based agencies in the country. And we wear that with a lot of pride. So we do enormous amounts of not only clinical work, we do interfacility transports, and we have started to really establish a rigorous pre-hospital research committee because, again, anecdotal experiences of we need to change things, research is going to what's going to back up all of those. So, I'm very proud to work with some of the most talented providers I have ever been able to meet. So.
That's great, and especially in the very niche space of community paramedicine, mobile integrated health. That is one area that, after speaking with a lot of systems out there, it's having the data to back up what they're doing in order to make the case. It helps make the financial case about what we're doing and how much of a downstream effect it can have for the investment in the programs that we do.
Yes, absolutely.
So if you want to go ahead and you could share your slides. I know you put together a presentation here and you want to take us through some of the great research and projects that you've been working on.
Sure. Okay. Let's see. Let me know when you can see.
There we go.
Okay. Perfect. All righty. So again, thank you so much for the opportunity to be here. I'm very honored, and I'm excited to be able to share a little bit about the work I personally care very much about. And I think it's a topic that is highly relevant to EMS clinicians and leaders, and I'll be talking specifically about female EMS clinician, occupational and personal well-being. And again, thank you for this opportunity. And before we, before we begin, I would like to disclose that the work presented here today was funded by a grant through the Katz Institute for Women's Health at Northwell. And I would also like to just say that I don't have any conflicts of interests to disclose. So today I have 3 objectives I'm going to be speaking about. And the first is to discuss the mental health and occupational concerns among EMS clinicians. Secondly, to identify unique occupational considerations that impact the mental and personal well-being of our female clinicians. And finally, to discuss future directions to improve female EMS clinician occupational and personal well-being. So with that first objective, let's get into the mental health and occupational concerns of female clinicians. So EMS clinicians are the ones who, without fail, show up on some of the worst days of our lives. Our communities rely on them heavily for medical intervention and care, disaster and crisis management. And because of this, they face significant amounts of stress, unpredictability, and often trauma on a regular basis. And there has been disproportionately little research focused on EMS clinician mental and occupational health, considering the stressors of their job. COVID has definitely placed this cohort more at the forefront. So it is refreshing to see, somewhat increased attention. However, it's still just simply not enough. And before we get into the specifics of our study, I do want to just provide a brief overview of the current mental health landscape of EMS clinicians. And it's a very important and under-discussed topic, and it often is heavily intertwined with many of the experiences of EMS clinicians, irrespective of gender, right? And EMS has been noted to be one of the most stressful occupations, largely due to the frequent and repetitive exposure to psychologically difficult and potentially traumatic scenarios. And because of this, EMS clinicians specifically have been reported to be at elevated risk for numerous adverse mental health outcomes, including depression, anxiety, PTSD, sleep disturbances, burnout. And the COVID pandemic, as we know, has exacerbated a lot of these outcomes. Pandemic-related evaluations of mental health outcomes have found prevalences of anxiety and depression among EMS clinicians to be as high as 28% and 38% respectively. There was even one study published that reported over 83% of EMS clinicians met the criteria for mild depression, 80% for anxiety, and 36% for PTSD. And for comparison purposes, in the general population, these prevalences often hang around 5%. And further, historically, EMS has some of the highest reported levels of burnout across all healthcare workers. Studies have found that almost 70% of paramedics specifically meet the criteria for burnout, which is almost double that of physicians and nurses and almost triple that of firefighters. And we know from recent studies that these adverse outcomes are persistent. And even years after the initial onslaught of the pandemic, our providers or clinicians are still experiencing these in very high proportions. Now, before I transition into our most recent work, I would like to preface by saying that despite what I present today, women in EMS find it as an inherently worthy occupation. I myself, as you know, after learning what I have, am in the process of obtaining my EMT certification. So that should speak volumes to how women at baseline view EMS as an occupation. So now on to our study, which was a mixed methods study labeled the Female EMS Experience, where our aim was to understand the occupational and personal experiences of female EMS clinicians. And what prompted this work was not only the impact of the pandemic, but there was also a paucity of literature that specifically focused on EMS clinician occupational health, and there was almost nothing on female EMS clinicians. And in an attempt to begin to address this gap, we first conducted a series of focus groups. We primarily recruited across Northeastern agencies, and we had 3 focus groups with a total of 22 female participants. And then we qualitatively analyzed these sessions and identified themes and sub-themes that elucidated what it means to be a female EMS clinician. And I'm going to be speaking about some of those specifics in subsequent slides. And in order to contextualize our qualitative findings, we conducted a cross-sectional evaluation, recruiting again from primarily Northeastern regions. We did have representation from other areas, but they were predominantly from the Northeast. And we sent out a one-time anonymous survey inquiring about specifics we identified from the focus groups. And we were able to get 161 responses, and that is a relatively small sample size. So, as a caveat, our results may not be representative of all female EMS clinicians. So just keep that in mind.
And Molly, can I ask a question about you?
Yes.
You are the expert when it comes to the research and the epidemiology and running these studies, but to most EMS leaders that may be listening that don't have as much research experience, when you say mixed methods, just to clarify, so you've got the 2 different cohorts here. One is more quantitative. You're identifying through surveys, information, and numbers. And the qualitative part are these focus groups where you're collecting stories to identify themes. And then do you take those the data set and 2 data sets together to try to create meaning between the 2, I guess?
Yes. So largely you conduct qualitative research or formative evaluations before you do anything quantitatively. And because, as I mentioned, there was nothing about female EMS clinician health at all. So, in order for us to really try and understand, we needed to get experiences. We needed to characterize and understand, what these individuals go through. And the best way to do that is through focus groups or, individual interviews. So we conducted our qualitative research first, and as much as I personally think our qualitative research spoke many volumes, we needed to be able to contextualize that to back it up essentially. And that's where the quantitative part is. Like, can I put numbers to what we found? So that's when we developed, after the fact, we developed this survey to say, hey, is this really the reality? Like, can other women in EMS back up what we found? And largely, yes, we did. So, I am a huge proponent of mixed method studies. I use it very frequently because obviously my area of focus is EMS occupational health. And hey, guess what? There's not a lot of research. So I tend to use this methodology very frequently. And I find that the qualitative research component is just so rich in knowledge and understanding, and it has really helped me be able to cultivate good research questions, to be able to really identify the true needs of our clinicians.
Great, thanks.
Yes, of course. Okay. Now, we did not collect specific demographic information of those who participated in our focus groups, and that was due to we really wanted to ensure confidentiality because there was the potential that I knew some of the individuals who participated. However, as anonymous as we tried to keep this, we didn't collect any demographic information just, for confidentiality. However, in our survey, we did collect some basic demographics. So to give some context as to those who participated in our survey, the median age of the female sample was 32 years. The majority were white, non-Hispanic, over half were EMTBs, and had a median working experience of 7 years. And again, I would like to note that not only the geographic, but also the racial and ethnic distribution of our sample was a limitation in our study. Therefore, again, our results may not be generalizable to all female EMS clinicians. Now getting into more of the nitty-gritty, we know that EMS is a male-dominated occupation with men comprising 72%. And although this gap is slightly closing, women still share very little space within this field. And women experience, across the board, very unique workplace stressors in comparison to their male counterparts, such as bias, discrimination, pregnancy, and even trauma. And women in general are at elevated risk for adverse mental health outcomes. So female EMS clinicians may be at even greater risk. And in our sample, we found that 53.9% met the criteria for probable depression, 70% for probable anxiety, and 41.8% reported elevated symptoms of burnout. And comparing to the global estimates I presented at the beginning, female EMS clinicians may be experiencing higher mental health burdens. And from our focus groups, I mentioned we identified themes and sub-themes, of which I'm going to get into some more detail now. And the following are not inclusive of all of the themes we identified, but rather a summation of the most concerning that were gender specific. And these included topics of sexism and harassment, pregnancy and maternity related issues, lack of career advancement opportunities, and lack of organizational support. And one of the most frequently discussed topics were sexism and harassment, which to be quite honest, we were really not surprised by. EMS is not unique to these issues, as they're frequently reported among male-dominated professions, including other first responding cohorts like firefighters. There's a wealth of literature there speaking to these issues. And again, women historically have not been fully incorporated into these cultures, so it's not surprising that these issues were highlighted. And again, over 70% of female participants in, our sample reported experiencing at least one encounter of sexism or some form of sexual harassment, whether that was verbal, physical, or sexual. The majority of the reported harassment was specifically verbal. However, what's more concerning is that female EMS clinicians are experiencing physical and even sexual harassment in very high proportions. And much of these occurrences were perpetrated by patients, but also by their fellow EMS partners and peers, which is very problematic. And again, unfortunately, these findings are not unexpected. They are on par what has been previously found in other first responding female populations. And here are some of the impactful participant quotes that we included in our publication that I just want to share, just because I really think it kind of hits things home. So one participant stated, and a lot of patients, partners, other clinicians do not respect our personal space. I've had multiple people on jobs literally walk up to me and just touch me without my consent. Next, another participant said, I'll walk in with a male partner. The people think that he's in charge. And also, I'm a critical care medic, so I have like the patch on and everything, and the doctor will just immediately start talking to my male partner. And lastly, women are still pushing to make a presence in the EMS world. Like, we still have a hard time struggling to prove that we are just as qualified or just as equal as the men that work. Yes, very, very interesting. So one of the second experiences that was specifically discussed in high frequency was pregnancy and maternity related concerns. And the following were not only reported by those who actually experienced a physical pregnancy while being an EMS clinician, but their partners also frequently spoke on behalf of their pregnant peers. And to be honest, as I had mentioned at the beginning, that some of these experiences reported were very surprising to me, particularly given improvements in federal and state protections and accommodations for pregnant employees. However, noted, not a clinician yet, so I really was not privy to many of the difficulties that pregnant EMS clinicians face. And I don't think I need to tell anyone listening how challenging it must be trying to intubate or perform chest compressions at 7 months pregnant. And some of the major concerns that participants spoke about were ill-fitting uniforms or uniforms that do not adapt to the changing pregnant body, the limited or unavailability and difficulty in obtaining a light duty position or those that are less physically demanding. Mentions of miscarriage and delayed family planning were also brought up on numerous occasions, which as a woman who experienced tremendous difficulty starting her own family, this hit very hard and very personal for me. And we actually, as I mentioned, we had a pregnant clinician who participated in one of our focus groups, and she had said, so currently I'm pregnant, and within working, I have struggled to find reasonable accommodations, or, even with a written doctor's note, I was denied a different position or a different job task. Another participant commented, and when we ask, why are there no accommodations for women who are pregnant? You either have the choice of putting your life or your child at risk, or coming to work very close at the end of your pregnancy to make sure you have insurance. And again, these types of experiences for me, I took very personally, and this has what truly has kind of lit the fire under me to try and make some good changes for women in EMS.
Molly, can I just chime in and say that
Yes.
These stories are compelling, and as leaders in our industry, I think everyone watching and listening to this session needs to really question the way things have been and talk to your human resources department. Find an expert out there that knows the law. Just because we've always done things certain ways does not mean the laws have not changed. And
Right.
I'm fortunate to know many organizations that do make accommodations for when women are pregnant in this field, and that have, while there may be a limited amount of light duty positions, it's almost required of the employer to say, oh no, we will create that environment that is safe. We will do a light duty position. I welcome any person on light duty that wants to help out in the office as far as the back end administrative work that we all need more support in. So
Right.
it is pretty shocking to hear that people today are still feeling this resistance, this perceived resistance, whether or not it's their perception is our reality. So we've got to question, I guess, what are we as leaders and organizations doing that's making people feel like there is no option?
Right. And there were some anecdotal experiences indicating that women have had to file bankruptcy because they had to completely leave the workforce because there was no light duty option for them. And, the financial struggles, because light duty positions, or if you go on leave, you take a percentage of your pay. So these are generating a lot of financial issues for women, familial issues, besides the apparent and obvious occupational issues. Okay. And from our survey, we did find that about a quarter of our sample reported actually experiencing a pregnancy while working as an EMS clinician. And of those, 43.6% reported having to take a leave of absence earlier than anticipated, citing medical necessity or the unavailability of a light duty position as the primary reason for their leave. And about half of the pregnant clinicians reported requesting pregnancy-related accommodations. However, those requests were only granted about 50% of the time. And lastly, a third of our sample reported utilizing lactation accommodations, and many of the women in our focus groups commented on the difficulties of breastfeeding while being an EMS clinician, and many said that it just was not an option. I knew my baby was a formula baby, which of course there's nothing wrong with that, but there was this expressed desire to at least attempt breastfeeding, and that unfortunately was just not an option for many women that we spoke with. And, the time intensiveness that it takes in contrast to the demands of their job was a major anecdotal barrier to doing this. And I think that this is again a very understudied aspect of maternity female experience within any first responding population and should be an area of focus.
Yeah, and especially looking at state laws in New York State, it is a state law since 2007, I believe.
Correct.
The employer has to make that accommodation, whether or not they think they can or not. These are things in which women can call, or people who are breastfeeding call out of service, call out in a detail, make sure that they have sufficient time in the safe space to do that. So, yeah.
And again, that is a provided option, but many women stated that they had to do it in the back of the ambulance because there was no time to walk to the lactation support room within the hospital because it was a 3-mile walk, So these are all, yes, they are provided, but again, there are still significant barriers that women have faced. Another primary theme that we identified was the impact being a female has on their occupational well-being, and the questioning of clinical capabilities was supported by both our focus groups and quantitative surveys. So about 62% of our female participants had their clinical judgment questioned by a partner or colleague. And again, similar proportions reported that they questioned or reconsidered their career in EMS, and workplace culture and environment was the top reason for their reconsideration, which should be sounding some alarms to leadership here. And
absolutely. Yeah, I would just, several of our speakers have pointed to the downstream effects of not only burnout and these conditions of culture, but also they've even pointed to the incivility within the workplace as a contributing factor to people's burnout, not as much the trauma that they see, not only the trauma they see, but how we treat each other.
Correct. And again, going along those same lines, female EMS clinicians also reported a lack of support, primarily from leadership or their organization, as having a significant impact on their occupational well-being. And speaking to some of these concerns, one participant said, "It's kind of sad to look back and remember, that I used to feel like I had all this room for growth and now feel like maybe I'm limited and maybe I need to choose a different career path where I don't need to lay on my stomach to intubate while I'm pregnant, or I don't need to carry somebody into their chair, where I can actually ask for help and not be judged because I'm a female. I don't think I really had a doubt whether or not I was continuing with EMS for the rest of my life, and now I do." So that is some of the unfortunate realities of what our female EMS clinicians are experiencing. And we also identified other issues throughout our focus groups, throughout our study, but these are rather ubiquitous to all EMS clinicians. So, the job demands, the physicality, the impact on family and friends, the disappointment and mistrust. And while there may be gender-specific components to these concerns, which there obviously are, as we, realized within our focus groups, we think as a whole that they are, generally experienced by every EMS clinician. So next, I'm going to speak about our second objective, which is to identify unique occupational considerations impacting the mental and personal well-being of female EMS clinicians. So addressing some of these concerns, particularly those concerning, mental health specifically, requires considerations that are very specific to EMS populations. And again, these considerations may or may not have gendered components to them. And the clinical reality is that there are very limited resources for most EMS agencies, and this becomes even more evident among those who work in a volunteer capacity. And the impact of volunteer versus paid status is something very important to consider, and it's largely understudied within EMS. There has been emerging literature within other first responding populations indicating that being a volunteer status may have a greater adverse mental health impact compared to those who are paid or of career status. And some hypotheses around that are that, they may need to work multiple jobs. They may have less extensive healthcare benefits. They may have less interaction or social connection with those that they work with because they kind of have unfixed or unpredictable schedules compared to their paid counterparts. So it's really important to look at this variable when we try to understand the needs of EMS clinicians and designing programs and interventions to address some of their top needs. And further, there are really limited specialized training opportunities for healthcare providers who work with EMS clinicians. And what often happens, and some of this has been documented in the literature, but also, with my discussions, anecdotal discussions with other clinicians, is that, they often find that their personal doctors or healthcare providers don't understand the realities of EMS or first responder work. And this was specifically mentioned in one of our focus groups where a pregnant clinician was frustrated with her OBGYN because she had literally no understanding of the physicality or the demand of her job. And this may exist as a significant barrier for EMS clinicians, especially if you're trying to initiate something like mental health care, where there is already significant barriers such as stigma, et cetera. So this is really important to consider when, training healthcare providers to treat this population.
If I could just add, Molly, I'd just like to quickly point to other sessions here at the EMS Leadership Summit. One of the main reasons we created this summit was to help democratize the information, to help people get access to more resources, because there was really a lack of resources. Maybe there was a lack of ability to get to those major national conferences that are out there. We have David Dashinger and Badi Rumley from the Responder Resilience and Responder TV network that have created a pre-resiliency toolbox. So the idea of, yes, you can respond, you can create more resilience, but can you do it in a way in your organization so that people have the tools before they're exposed to the occupational stressors? Dr. Megan McCleary's work at the Wayfound Mental Health Group, she has a researched method for beyond operational stress. Again, the how do you give people the tools to deal with what they're going to see ahead of the actual stressors? And we've got a 5-time returning speaker, Wendy Lund, who talks about really the wellness approach, that not saying it's an easy approach, but how do you use mindfulness practices, and how do you create an environment for yourself that values, your own physical and mental health, and put those structures in place. And so we have several different speakers that we've designed around this conference to, again, give people more exposure to other tools that are out there. But I would agree, it is not easy to find access to those tools in the world if you don't have like a directory, I would say, of some incredible resources that we found. So.
And I will be commenting on a couple of those topics that you touched on a little later on. So I'll save that. Next, daily work-home transitions are, again, another important thing to consider and have not been talked about very much in the literature. The concept of reintegration has received a lot of attention among our military post-deployment, so that reintegration back into society. And while EMS is a very different population, we can kind of think of the stress and, the potential trauma that EMS clinicians experience on a day-to-day basis in a similar capacity to deployment. And EMS providers transition to home on a much more frequent basis, often without any training or skills on how to do that, on how to cope with what they just experienced, or their very highly stressful and disturbing incidents. So this has become also very increasingly important for our female clinicians who, when they get home, often have to instantly transition into mom mode or caregiver mode. They are not fully equipped on how to do that. How do you go from, a pediatric cardiac arrest to seeing your child of the same age? How do you cope with that? And a lot of individuals are not given the skills or taught the skills or provided the emotional awareness on how to do that. So that's another very important occupational consideration. And lastly, the typical schedules of EMS clinicians are another important consideration when thinking about developing any type of program or engaging them in any type of intervention. EMS clinicians work for multiple agencies, as I mentioned. They hold multiple jobs. Further, familial obligations often fall to the mom, right? So that also complicates availability and scheduling and flexibility. So all of these are very important clinical and occupational realities that we need to consider, if we are to address or attempt to address some of the major issues spoken about. And I also think it's worth highlighting the significance of stigma as we, think about how can we make improvements for not only our female clinicians, but all of our EMS clinicians. And it's important to kind of take, a little step back and think about their cultural context. EMS is male dominated. There's a lot of mental health stigma that continues. There's relatively low level of knowledge or emotional awareness. And, this mentality to not react to trauma or emotional distress or hardship, or that if you do, it's perceived either by yourself or others as a weakness, or it's an indication that you are not good at your job. You are not a good clinician if you experience an emotional reaction to a critical incident. And it's almost expected to experience all that you do and then somehow shut that down. However, we know that that's not the reality. I mean, just look at the PTSD rates, right? And, you are a human with emotions and will be impacted by them. And, stigma has continuously been noted as one of the main barriers to seeking mental health treatment across first responders. Thus, it just continues to perpetuate this cycle of trauma and very high prevalences of significant mental health burdens. So getting into our last objective, I'd like to just discuss some future directions on how we can best improve female EMS clinician occupational and personal well-being. So I think since publishing our work, we have found ourselves at a crossroad, and it may not be a welcomed one, but we believe it has presented us with a unique opportunity for growth. And now I clearly do not have all the answers. I do not comprehend the nuances of EMS systems, operations, administration, et cetera, for me to be able to truly speak on addressing some of these issues discussed here today. So my question to anyone listening to the greater EMS audience is, where do we go from here? How can we best take what we have learned and work towards creating systems and environments that effectively engaged female EMS clinicians? And the obvious and ultimate goal is ensuring the sustainability of EMS. And we truly believe that the inclusion of women will be a necessary component to that. And I truly believe that EMS has that capacity to change, but it is dependent on our willingness to do so. And again, I currently do not have all of the answers. I work with some of the best and brightest in EMS, and even then, we don't have it figured out. And this is going to be a collective effort. So we are reaching out to our clinicians, to our leaders, to help us move into not a new direction, but let's say a modified direction. I think that's a little more palatable, a modified direction, right? And I think we're headed there right now. We're educating, we're raising awareness to these issues. We're speaking about, the concerns of female EMS clinicians and their experiences when nobody spoke about it before. There are plenty of other opportunities to catapult change, increasing access to things like resources and accommodations for pregnant clinicians. And I will shamelessly advocate for more research. This is not, and it cannot be the end. We need more studies and more diverse female populations if we truly want to see their continuation in the fields. And we also need to, I think, encourage clinician participation in research. Studies among EMS populations are notoriously low samples, like less than desirable samples, right? Like I get excited if I get over 100, which, is a sad reality of research. So we need to be able to engage our clinicians, in what we're doing as far as research, if we're really going to understand how best to address their needs. And based upon our work, we believe that, there may be some mechanisms of change that could directly some of the issues we presented today with specific regards to our female EMS clinicians. And, we may propose that we could increase education policy and action to reduce and prevent episodes of workplace harassment. Provide resources and support to those who have experienced it are critical. And, we recognize that workplace culture does not change overnight. So this is going to take a lot of time and dedication and effort. And secondly, there is a dire need for us to reevaluate what reasonable accommodations are for pregnant clinicians. For myself and my team, we have recently been focusing on, the idea of light duty positions. And we know that ensuring light duty positions is simply just not an option at many EMS agencies. I work with one of the largest agencies in the country, and even then we are limited in our capacity. So, we've been recently trying to come up with potential and creative solutions and have applied for some grant fundings to support them. And while we have no clue how this will all turn out, we are willing to try and take that initiative. Apologize for that. And lastly, thirdly, we also believe that there is a need to incorporate psychoeducation and awareness of mental health concerns among our clinicians. And this will not only equip our clinicians with the knowledge and understanding of what they may or may not be experiencing, but it will ultimately decrease that pervasive stigma.
Molly, can you talk a little bit about psychoeducation and what exactly that is?
Sure. So psychoeducation is very simply providing the knowledge to clinicians on being able to recognize what is stress, what is the typical maladaptive response to stress, what's a positive response to stress. So, this is providing, and like I said, equipping EMS clinicians on not only understanding what it is, the reaction to it, and how to have a more positive way of navigating it. Stuffing it down, deep down inside, that's not the best thing. And, I think that incorporating these topics within EMS curriculum exists as a preventative investment. And by introducing these concepts early in their career may reduce, the probability or severity of developing adverse psychological outcomes. And this is even more important for our female clinicians who at baseline are at elevated risk. So we no longer can put the Band-Aid on the bleed, right? Our traditional reactionary approach, when things get really bad, then we'll try and focus on it. That's insufficient. That we can't do that. That's not sustainable anymore. So by equipping our providers with, okay, this is what I'm experiencing, being able to recognize what they are experiencing, like put a tangible term to it and give them the strategies to be able to cope and navigate that, whether it's by themselves or be able to have that strength and courage to reach out for help. That is absolute education that needs to be taught. This is not inherent to every individual. This knowledge is not well understood. This needs to be provided to our clinicians if we are truly going to be able to reduce, these significant proportions of burnout and anxiety and depression. Because again, we're getting to the tail end of it when all of you already have it, and we're trying to put Band-Aids on it and try and, ameliorate the symptomatology when we could have had an opportunity to prevent it in the beginning.
And Molly, I so love that you brought these topics up. This is really the opportunity for us all as an industry to develop more awareness. I'll point to Dr. David Daniels' research in psychosocial hazards and the safety community, and specifically in fire and EMS, his research. And I would think I was most shocked when his research tool asked you, it's an inventory of 100 questions. And I found myself answering the questions. It was a not frequently, infrequently, frequently, very frequently exposed. And every question revealed another piece of awareness. And it turned into frequently exposed to all of these hazards, which I personally didn't have language to even know what to call them before.
Right. And I think being able to articulate what you experience is the first step in understanding and how to adapt and how to cope and, heal from, what you experience as an EMS clinician. And lastly, we spoke about the clinical realities of EMS work that require specific considerations when attempting to engage these individuals in any type of program or intervention. And after this presentation, I hope that I have expressed that females also need specific considerations. So, tailoring to the female EMS experience will become a necessity if we are to, effectively engage them, within programs, within the workforce, et cetera. So in closing, I again want to reiterate that the female EMS clinicians in our study find it as a challenging yet necessary and important occupation. Despite experiencing, the workplace challenges, these clinicians continue to show up to their jobs, engage, and provide life-saving care to their communities. And I would like to relay a particularly meaningful quote from one of our participants. And she said, "I love being a medic. I have gone to school. I have gotten degrees. I love this job. And I feel the experiences that I have had molded me into that stronger person. And I feel like I've taken that strength and brought it to even other areas of my life." So there is a need to not only continue to attract, but to retain female clinicians in the years to come for our patients, our communities, and our health systems obviously benefit from their inclusion. So again, I would like to thank you and express my gratitude for the opportunity to share our work with you today. I also need to thank Northwell Center for EMS because without their continued and unwavering support, none of this research would have been possible. I also feel so fortunate to be able to work with such talented, selfless, and dedicated individuals. I also obviously need to thank the Department of Emergency Medicine for they provide me with the time to pursue my passion, which is improving EMS occupational health. And I have provided my contact information, so I do welcome any comments, questions, concerns, and you can find more about our study, which is titled The Female EMS Experience, and it is currently in press in pre-hospital emergency care.
Molly, thank you so much for sharing this body of research, your passion for the topic, and really helping us all improve the industry. It certainly is going to be more effective when we have the numbers and the research and the stories to help back this up.
Absolutely. Thank you again for this opportunity to share what we've learned. And like I said, we're not going to stop.
I love it. I love it. And folks, you can visit our research corner in the EMS Leadership Summit's exhibit hall. So you go to emsleadershipsummit.com/exhibit. You'll see the Northwell Health and the Center for EMS booth, and you'll be able to click on that and access additional resources. So we're really happy to have an EMS research corner dedicated in our exhibitor hall where it's going to have resources for the time to come. So Molly, thanks again for sharing with us, and thanks for all the work that you do.
Thank you. It was a pleasure.